I thank organizers for giving me this opportunity. And topic for today is mechanical circulatory support. It's a very vast topic, and which is a topic which requires both cardiac surgeon and interventionist with critical care physician and nurses to work together as teams, because it includes a lot in it. Let's go into our talk. So what are MCS? So these are the pumps designed to assist and replace the function of either left or right or both ventricles. These devices are indicated to provide hemodynamic support to patients with cardiogenic shock or symptomatic advanced heart failure refractory to guideline-directed medical care. It decreases the workload of the heart while maintaining the adequate flow and blood pressure. The common terminologies we come across: bridge to recovery, where these are the potential reversible candidates where they can have the insult because of acute myocardial infarction or myocarditis or post-cardiotomic cardiogenic shock. And bridge to transplant candidates are the patients eligible for heart transplant and destination therapy where recovery or transplant is not possible. So what guidelines says for initiation of MCS? It's always crucial to initiate it at the earliest. So early initiation gives us good outcomes. So generally the accepted guidelines, despite of an optimal medical therapy with cardiac index less than 0.8 to 2.2 liters per minute per meter square and systolic BP less than 90, pulmonary capillary wedge pressure more than 20 with right atrial pressure more than 18 to 20 with evidence of poor tissue perfusion like oliguria, mental status change and cool extremities. So contraindications for mechanical circulatory systems, it includes irreversible or renal, hepatic or respiratory failure, sepsis and significant cognitive decline. So what are the indications for ventricular assist devices? So chronic heart failure with severe LV dysfunction with functional peak oxygen consumption less than 14 on peak exercise with the New York Association class 4 dyspnea for more than 60 days or NYHA class 3 to 4 within a month with IABP support for at least 2 weeks or 2 failed attempts to wean from inotropes or increased diuretic requirement symptomatic despite of CRT or inotropic dependence. In acute setting, again acute fulminant myocarditis, acute MI with cardiogenic shock and postpartum cardiomyopathy or Takotsubo or post-cardiac surgery and bridge to recovery. So approximately 80% of VAD implants are for BTT, bridge to transplant. So they are classified into 4 groups based on the different properties. Based on the pump mechanism, there are pulsatile pumps, continuous pumps. Continuous pumps include axial, centrifugal and mixed. And based on the location of the pump, there can be intracorporeal or extracorporeal. Based on the ventricle supported, it can be left ventricle, right ventricle or biventricle. Based on the duration, it can be short term, long term. So types of mechanical circulatory support, it can be short term support like IABP or ECMO, Impella, ACPella, tandem heart, and long term supports, it includes 3 generations of pump. First generation pulsatile flow pumps, second generation continuous flow pumps, third generation centrifugal pumps. So let's look into short term MCS devices. One is IABP, which is commonly available in majority of the centers. This is to the right of the screen is the console of the IABP, and to the bottom is the balloon which we insert through the groin into the aorta, and it balloon inflates during the diastolic phase. In the same is depicted on the screen where an ECG showing the diastolic balloon inflation causing diastolic augmentation of coronary perfusion and assisted short of time. And for HRPCA, again, it is class 2B indication, and in shock, ESC doesn't recommend. Coming to VA ECMO, it is again a different type of short-term pump where we can get the deoxygenated blood from the venous system into the oxygenator and put back into the aorta. The main thing is it increases the filling pressure and preload, afterload, and LV wall stress with myocardial oxygen consumption. It provides 5 to 8 liters. Coming to Impella, it works like concept like a submersion motor where it works with Archimedes principle, and the blood is aspirated from the LV and pumped into the aorta. There are different sizes of pumps available based on the requirement. So before understanding, we must know about the pressure volume loop hemodynamics. So these AMCS devices will act on the left ventricle. So IABP mainly acts by reducing the pressure, keeping volume constant, whereas ECMO increases the pressure, but it also keeps the volume constant. Tandem heart reduces the volume, but keeps the pressure constant. But impeller reduces both pressure as well as the volume. So advantages in protected PCI, it reduces the MACE rates, increase in ejection fraction, and reduces the renal dysfunction. So coming to a case example, 54-year-old male, diabetic hypertensive, admitted with ACS STEMI with left heart failure and episodes of NSVT with very bad coronary anatomy, refused by surgeon for immediate surgery with high syntax score, Euro score and CHIP score. The strategy was, we thought we'll do image-guided plasty with impeller support. Right heart catheterization was done, and as well as left heart for LVEDP monitoring. We put in impeller, proceeded with angioplasty, showed critical disease of LM, LCX and LAD, stented LCX, later stented left main LAD. We did a tap followed by kissing balloon inflation for these beautiful results. Then in cardiogenic shock, I do have two cases. Let's move on to cases in view of shortage of time. So this is a 32-year-old young man presented to us with NSTEMI, acute LV failure, NSVT episodes with SCAI stage C with a severe LV dysfunction, technically inoperable candidate because of high risk with proximal LAD, diffuse lead disease, CTO of LAD and RCA, hemodynamic parameters, EDP were high, filling pressures were high. So heart team discussion, then we decongested him adequately and took him for ECMO-assisted multivessel PCA with IABP. So ECMO cannula was inserted through his left vein and artery, and 21 French vein and 14 French arterial cannulas were inserted through the right groin. We could comfortably finish the LAD and RCA angioplasties. And this was a classic case. Again, we had a challenging ECMO cannulation. Patient with anteroval MI came to our ER, arrested, STEMI, VFVT, recurrent DC verted, and he was put on ECMO in bedside. Later on, his anatomy, LAD was diseased, we stented LAD. This was the echo in his emergency room, post revascularization with MCS support. After 3 days, his heart recovered quite well. So in cardiogenic shock, we need to decide whether we need a chronic support or temporary support. If it's a chronic support, we need to think about durable or long-lasting devices till the transplant. And for temporary, we can use impeller, ECMO, IABP, and tandem heart. But whatever it is, we need to plan an exit strategy as well. So long-term MCS, this includes the third generation one. Of late, they are in the market, that is HeartMate 3, and total artificial heart, which was first, which came into market with replacing both ventricles. That is, it takes care of both right and left ventricles. So key to success, selection of the right patient and right indication, initiating at the right time, and utilizing the right disposables and regular practice. Along with that, shock team approach, which includes interventionist, heart failure specialist, and cardiac surgeon, intensivist, technicians, and nurses. To my take home, choice of MCS depending on clinical and hemodynamic data, time of initiation is very important, ease of access, local expertise, vascular anatomy, and exit strategy has to be planned. One must learn to use more than one device and combination of devices as escalation and de-escalation strategies, and algorithm for using the pump for short-term pumps and long-term pumps. So short-term pumps for bridge to decision, bridge to recovery, whereas long-term pumps for bridge to transplant and destination therapy. Thank you.